Good morning, everybody online. Good morning, everybody. At 9 o'clock, we're gonna get started. Welcome to our review for January 2026. Our first report is going to be Brooke Thomas doing a STEMI report.
Okay. Morning, everyone. Happy to be here. Over here. Okay, so the first case that I thought to present came from Park County. This was a 64-year-old male that came, was called out for altered level of consciousness. A bystander heard him yell and turn in circles and then fall to the ground. EMS arrived to find him sitting and kind of drooling outside of his mouth. He told EMS he was stung by a bee, but I kind of wonder if that was his heart attack. Either way, he did become nauseated, pale, diaphoretic, and had shortness of breath. They did a 12 lead on scene, which was noted to have SC elevation and AVL, and reciprocal impressions. The STEMI alert was called ahead to Union, and the EKG was transmitted. There was some difficulty to read it by the provider. That's incidental. They did go ahead and do another one once they got here, confirmed it, cardiology consulted. It didn't cause any kind of delay or anything. In the cath lab, they found a right coronary artery with a large dominant vessel. This was the culprit vessel, and it had a 75% ulcerative plaque in the mid segment, which they did successfully stent. He recovered in the ICU and unfortunately signed out AMA, and we lost him. So please stay away from bees. Here's your guys' run history. All the times look phenomenal. There was a bit of a delay once they got to Union. However, that was of no fault of the EMS care provided. There was some other issues that had occurred. But either way, our door to balloon time was 87 minutes, and the first medical contact was 121. So nice work there. That's the EKG. It was a little kind of foggy. I don't know if it was our EKG or however it got transmitted bridge. I'm not sure. But they did another one quickly since they knew he was coming, just to confirm. There's our EKG. And there's this cath images. You can see that right coronary artery, and then it got stented. So highlights, obviously you guys EMS identified the elevation quickly and called ahead. It was a unique presentation. Bee sting, heart attack, one will never know. But there was prompt EKG and notification to Union by EMS. Although the transmission was difficult to read, like I said, we got one quickly. All the goals were met for EMS, so great job to you guys on that. Then anybody have any questions about that one? Okay, on the next one, this came in by TransCare. 56-year-old gentleman with chest pain. He reported he had vomiting along with the chest pain, which radiated down his neck and his bilateral shoulders. Now, this weather during this time was real gross. I know there was a lot of snow, a lot of cold, a lot of ice. There was a lot of debris on this patient's porch, so getting to this patient was delayed slightly, not by much. He did complain of the chest pain, so they gave the aspirin, got the 12 lead, did show the ST elevation with reciprocal changes. STEMI alert was called in ahead, and they took him urgently to Union. Upon arrival, they did a subsequent EKG, which indicated progression of these changes, so cath lab was active quickly. He did have multivessel coronary artery disease and cardiovascular consultant. He did have a 3-vessel bypass 4 days later and was discharged home 7 days after surgery. And when I followed up, he is participating in quite well with cardiac rehab. Nice job. Again, all your times look phenomenal. The call to arrival is probably delayed because of the weather during that time. I think that's when we had all that snow and then it became ice, so to no fault of your own. We don't have a door to balloon, obviously, because he didn't have an intervention. They called CV surgery. So there's the EKG from EMS and then our EKG. And you can see those cath images. That right coronary artery had a 70 to 80%, and then on the left side, he had an 80 to 90 in the LAD, and first obtuse marginal was 80 to 90. So he had some pretty significant diseases there. Despite the weather, everything moved quickly and expeditiously to get the patient here safely. They got him in the ambulance, did a quick assessment, identified the STEMI, got things called ahead quickly. Also, EMS completed the blood draw prior to arrival, so we definitely appreciate that. Allowed for a quick turnaround time blood and other labs. So thank you guys very much for that. And that is all I have. So thank you guys. Any questions?
Thanks, Brooke. Appreciate that.
No problem.
Next up is gonna be Beth doing a stroke. report. Thanks, Beth.
Morning, everyone.
Hope you there.
Yeah. it's all-
No, you won't. It just messes up on its own.
I do have a report for Union this time. I apologize. I don't have one from Clinton this time because I did not have any EMS runs in the medical records of any recent patients. So I'm working on that to figure out if they're just not coming in by ambulance or what's going on with that. Because you never know, it's Park County, you know.
They've been
Come in,
flying.
they come in instead of calling. His history is a 66-year-old male patient. He was independent, lived at home with his wife. Prior medical history included pneumonia, pancreatic and prostatic cancer, hyperlipidemia, and a stroke. Not on any kind of anticoagulants because he was a chemotherapy patient. And he was on multiple medications. Oops. EMS was called for a fall, slurred speech, and left-sided weakness. Upon arrival, the patient was found sitting on the toilet being supported by his son. The patient report, he woke up feeling fine. He ambulated to the bathroom, then he became weak and off balance and fell, striking his head. His last pneumonia was established at 07:45, and he reported no blood thinners. He was placed in a stair chair and was transferred downstairs to a cot. Cardiac monitor, sinus rhythm, his coma scale was fine, blood glucose was fine, pressure was fine, everything looked good. IV was started and he was transferred to our ED, and his symptoms did improve en route. The Cincinnati pre-hospital stroke scale was positive. The VAN score was not completed. His GCS was 15, and a stroke alert was called via iHearn en route. Here's the run times. They look really good. Notified at 08:27, dispatch 08:28, en route 08:31, on scene at 42, and outpatient at 42. In the emergency room, he went directly to CT, 1 per EMS card. His NIH when he arrived was at 6. CT had stroke at 09:20, and it was negative for a bleed. They didn't call and consult our teleneuro service, and TNK was advised. TNK was admitted at 09:40 for a 30-minute door to needle time. So that all went very well. His assessment at 10 showed left upper extremity movements, but he was more robust, but his speech was slurring. CT was completed at 11:14, and it did show a small acute infarct to the anterior at the frontal lobe. An MRI was completed at 16:45 and showed an acute infarct in the right anterior MCA territory. He was admitted to ICU. He was transferred to the stroke unit on 10/2, and he was discharged home without patient therapy on 10/3. The really strengths of this was the hospital scale was completed, the stroke alert was called, and there was very good documentation in this chart by EMS, so hats off to you. One sad thing about this patient, he did come back and he did have an embolic shower, and he did pass away in our GIP hospice unit. He did restroke in about 4 days. So, but it was a very good job, and he had very good care from EMS in the hospital. He was here.
Stroke at that few days is pretty kind of rare, right?
It is, but I think with his condition, you know, that cancer, just do anything about it. So
Just a sick guy.
it's a big guy.
Well, thanks, Beth.
Thank
Appreciate
you.
it. Next up, the trauma report with Tina. Oh, I hate pick on me. I'm gonna tell everybody I hate pick on me. Okay, just tell me.
Well, you can tell since your wine has that.
Picks on me.
There's pictures I'll pass around. Those are just different types of lace. And there's obviously that guy's hands that are hard to tell what in there. The mangled mess it was. So this is an industrial accident. A 64-year-old male. 911 call came in at 7:15, was dispatched 7:16, route at 7:16. On scene at 7:21. They departed at 7:34 and at Union at 7:56. So this goes over to Clayton County. Call dispatch was 1 minute. Was dispatched en route of 0 and route to arrivals 5. On scene to departure was 13, departure to arrival 22. Total call time 41 minutes. So they were dispatched to a factory for an unknown medical. On arrival, patient was reported to have his right hand caught in a piece of machinery, causing amputation right index, middle, and ring finger. The employees, apparently their EMS people on site did a really good job. They split it, wrapped it, and was controlling the bleeding. They put 2 liters on him. 3 EMS on site. Patient was awake, alert, in the morning, and he was able to pivot to the cot, take him to the ambulance. They did not take off the dressing, yay for them. Because bleeding was controlled. Vitals were pretty good, little 130/90. GCS was 15. He was rating his pain 8 out of 10. Took him 3 attempts to get his IV. They did 4 leads, and he was in normal sinus rhythm. They gave him 100 of fentanyl. Had to give it intranasally while they were trying to get his IV. Finally got one going, gave him some saline. They gave him a 500 cc bolus and gave him Rocephin, yay for them. And his pain wasn't relieved much, so they gave him 20 of ketamine with no response. So they repeated it 7 minutes later, got his pain down to a 7. So they called with a trauma alert, again, yay for them. Transported the patient without his digits. Employees state that they were too damaged and stuck in the machine. They did end up bringing them in later in some ice. Pre-arrival, 3-finger amputation, machinery, forearm, right open fracture. But they initially was a level 2, later it was upgraded to a level 1 bucket. Trauma surgeon was paged at 8:30, got there at 8:35. These are our trauma activation criteria. He did have an open fracture of his forearm, so I think that's why they initially called it a level 1 or a level 2. But as you'll see later, this ended up being a crushed and mangled, not just indicated. Even though it wasn't extremity, you'll hear more about why they should have called this a level 1. So trauma activation was a level 2. They upgraded it to a level 1. 64-year-old male. He presented to the emergency room, getting his right hand and forearm stuck in the heavy machinery at work. Presented with significant open fracture, in addition to right, 2nd, 3rd, 4th finger amputations and the open right forearm fracture. Had all this stuff by EMS prior to arrival. He was of course, that arousal BCS was 15. The right upper extremity with a large open fracture. The bone was visibly protruding out his wound. Had an amputation of the 2nd, 3rd, 4th digits. The 3rd and 4th were not only just amputated, but declared and amputated at the digits or at the digits. Had pulses in the right upper extremity, bleeding controlled. There was no movements of the fingers, right upper extremity to command. Vitals were still stable. He's on 2 liters. Right mid forearm open fracture, about 1/3 circumference open wound. Minimal bleeding on the dressing on the outside. There was a little bit more when they took it off. This is from the trauma surgeon. There was 1 twitch from the right thumb. No visible hand motion otherwise. Had a palpable pulse, good capillary refill distally. Multiple amputated digits 2 to 5, and there was exposed bone. So he had radial fractures, ulnar fracture, and a distal radial ulnar dislocation. The right hand had partial amputations of the 2nd, 3rd, and 4th digits, and then they did labs and type and cross. Let's see, that's just the same thing. And then trauma consult in the ER said it was a mangled right upper extremity. They discussed with the ED and ortho hand, recommended for transfer to a level 1 tertiary center immediately. With the zone of the injury and mechanism, the quality of the tissue, there is no chance for reimplantation of the digits. Diagnosis was open fracture, radial fracture, traumatic amputation of multiple fingers. They cleaned the wound, they talked to IU, they said, splint it, don't try to reduce it, which they did not. And then he was transferred by ground, LS, because they couldn't fly because it was stormy. So these are the x-rays. You see where the fingers, and you can kind of see where there's some dislocation possibly of those fingers. And then the fractures on the right, on the arm, there's actually multiple fractures there. So what happened was it wasn't just a machine, it was a lathe. So you see in those pictures, they are big, gnarly, nasty machines. And one of the things I think in the factories, they tell them, first thing they talk about is safety, and accidents happen, but you don't wear anything loose, nothing dangly, you keep your hands away. You guys have a buddy that can kill it when it, if something happens. So not only did his hand get caught in it, but those rotate so fast with so much force, it's pulling and twisting. So those fractures were more than likely from him, that arm getting twisted like that. So Dr. Lynch did make note in his documentation, he thought they would probably end up having to amputate that arm about midway because the tissue damage, because when it didn't just cut those fingers off, it pulled them off. So, and when that happened, there was tendons actually that went with it, and they could see that attached to the fingers that they brought back in. It was a nasty.
That's why the pain, yeah, that's why the pain, well, that's why the pain meds didn't touch it.
So,
Give him all the pain in the world.
it's really important when EMS calls this, try to be as specific. If it's a machine with a clean amputation, in which they didn't know, they may have been going by what they were told at the factory. But if you know it's a lathe, that's going to be
I think they red flags though, because the factory told them that they couldn't get the fingers out because there was too many.
That main point, that was kind of a hint. They weren't just amputated, they were crushed and
Well,
pinned.
they did bring him in eventually though, right?
They did.
I think the company did though, right? The company finally,
Somebody.
I think the company got him out of the machine and brought him
Yeah,
in.
it wasn't EMS, it was
But
somebody.
it's like Hannah just said, can you imagine the tendons and the nerves and all that? It's like,
It wasn't, like we talked before, it's not just what happened, but what caused it. You're not looking just at the site of the initial injury, what else has been damaged, so it's not just about hemorrhage, trying to minimize loss of tissue and loss of function as much as we can. There wasn't probably anything that was gonna make us any different, except we could, if the trauma surgeon in honestly would have been made a difference, because they couldn't do anything really. The important thing was to get them out of here, and they did. And unfortunately, we don't hear from IU, so I can't tell you what exactly happened in the end, but in my understanding. That's all I got.
Thank you very much, Tina.
Thank you.
Next up, we do have a case presentation by Arlington Hain. This one, is just very interesting. Yeah, it's just very.
Therapies.
Yeah. Just,
Hello, everyone. So this happened back in December, pretty late, around 11 o'clock at night. Medic 9, as well as pretty much everybody else, we're dispatched to residents to respond to a residential structure fire with confirmed entrapment. We had a little bit of history with this patient and address. We've been there multiple times for this guy who loves to smoke with his oxygen on, blows himself up. So who started the fire? Maybe. This crew, he's a male in his 50s. He's blind, COPD, diabetes, various cardiac problems. Engine 6 were first on scene. They made entry, made the grab, removed the patient from the residence. When we got there, the patient was found alert and oriented. He was singed, there's steam coming off his body. He was laying next to the driveway. He had soot around his nares and his mouth, as well as part of his tongue. Patient was in severe respiratory stress, complained of breathing problems. So our first thoughts and concerns, airway's good now. What about 5 minutes from now? What about 10 minutes, 15 minutes, etc.? We do anticipate swelling due to the presentation. The past medical history that the patient has definitely is taken into consideration, mainly with the COPD. How well is he going to compensate, and how acutely will he crash and deteriorate? Patient voice concerns about being intubated. He's like, "Hey, I know this song and dance. I really don't want to." We're like, well, we really need you to reconsider. And after some back and forth, he's like, all right, fine. Because we basically told him like, well, we cannot intubate you, but if your airway swells up, we're gonna have to cut a hole in your neck. And so we said, hey, I've intubated before, but as far as cutting your neck open, I haven't done that yet. So
That might be the day.
So eventually he consented, and then, you know, we're starting to implement the preparation phase and the pre-oxygenation phase of getting ready to RSI this guy. So again, we hope for the best, but we are going to prepare for the worst. This is initial, and then 5 to 10 minutes after for various patients that have airway burns. In the ambulance, his vitals were relatively okay. His blood pressure was a little elevated, heart rate was a little elevated. His SpO2 is 92% with the 15 liters. However, how much of that is carbon monoxide? Who's to say? He did have a GCS of 15 and his shock index is 0.8 at the time. We tried for an IV, couldn't get it due to high probability of airway compromise. We said screw it, it's IO, which was interesting because most people, whenever you flush it, they'll tell you, oh crap, that hurts. He like barely was phased about it. So we're like, okay, cool. The burns that he had, he basically had them from underneath his armpit all the way down to his hip, 3rd degree. A little bit on his knees and hands, like 2nd degree-ish on his neck. So we started the 1,000 bag with the pressure bag, 3 to 5 words between breaths, continued respiratory distress. So 7 P's, right? Preparation, pre-oxygenation, pre-medication, positioning, paralyzed, pass the tube, and then post-management. So basically me and my partner were like, hey, we're gonna RSI this guy. We had all of our equipment out. We did the pre-oxygenation with the 15 liters. We didn't really have to do anything else as far as pre-medicate. We didn't suspect any head injury. We had him in high Fowlers already since he was in respiratory distress. For paralyzation, we carry sucks, confirm with TCO2 whenever we pass the tube. So emergent transport began pretty promptly once we got a driver. So we got there roughly 2 to 3 minutes after engine 6 did. So for those of us who aren't fire-based or don't have too much fire experience, there's a lot of things moving at the same time whenever people first get there, especially for a working fire. So it's kind of difficult to find somebody, say, hey, we need a driver so we can get the hell out of here. Luckily, Car 51, they're like, hey, we can just come back later. So he offered to drive us. Basically, as soon as we started rolling, we hit up Union and we said, hey, we got level 1 coming. We voiced our intentions to RSI. We'll be there about 10 minutes. The patient was estimated to be about 110 kilos. We gave him 250 of ketamine IO. One of us was working on the sucks while the other person administered the ketamine. And, you know, ketamine roughly takes effect pretty promptly, 30 to 60 seconds. And we were still working on the math and everything for the sucks. And my partner's like, hey, he's still like wide awake. We're like, oh, well, you know, maybe it's adrenal response or something else. And so we're like, okay, screw it. We want to make sure that you're comfortable and good to go. So we gave him another 200. But no desired sedative effect was happening. So we looked at each other. But man, this guy has 450 of ketamine on board. He's still wide awake talking to us. So I'm still here. We're coaching. We're like, all right, bud, just, you know, get your head back, go to sleep. You know, we'll take care of you. He closes his eyes, and then we're like, okay, I think he's good. And he's like, nope. It's not good. So we gave 30 of etomidate. We were like, maybe this guy maybe the ketamine was swapped out with saline or something. You know what I mean? Like, so despite escalating sedative dosing, the patient remained awake, verbal, and protective as airway reflexes for now. So what do we do now? Right, that was the big question at that moment. So this RSI had turned into a DSI, which, you know, happens sometimes, but it's not preferred. Do we give additional sedation? The only thing that we carry for sedation at that point is Versed. Do we just say screw it and give the paralytic? And obviously that's not the right choice. The patient remained conscious and verbal despite escalating sedation. We ended up electing not to paralyze him because what that worked, but the sedation didn't, you know, big no-no zone. the decision was made to defer paralytics, right? And so we just basically expedited transport. We basically just continuously assessed him. We got out our cric kit in case things worsened. And basically that was it. The outcome, Lifeline later picked him up and got him over to Eskenazi, didn't get intubated later. I'm not sure how long it was, but
It was not as fast as we would have thought, that they said within a half an hour,
Yeah, they're-
like,
okay.
yeah.
At one point in time, we had heard he had a 9% airway obstruction, that's it. I mean, even with all of that, so the swelling that you would have anticipated.
Your people took them, you know?
Makes you wonder if
It
the
was
IO
quick
was
though,
good.
Kyle.
It was 30 minutes. It was 30
I thought
Even that first part of it,
It was the IO.
It was a conversation.
Yeah.
That's a fair question, never thought
I
about.
mean, it was the IO now.
Was the IO?
Well, they got air return and we gave a whole liter of fluid with no extra
I thought he was
vasculation.
supposed to be
Remember
intubated in the ER.
the femur or
I thought he
the
was refused.
leg.
And I thought that's when I read it.
Our documentation, they refused here.
There's
That's what I
a
think.
huge note from the doctor
Yeah.
regarding the discussion and that he was alert and oriented and this nurse witnessed it and it's a huge note.
Yeah, and Kyle's team, I think, even had to do some convincing.
Our team as well had like a timeout coaching moment, make sure everybody was, on the same page, that he understood the what happened and the outcome and so on and so forth. And he again was conscious and alert enough to refuse, and they made the right decision, I think. I definitely think that situation, you guys were great, had everything prepared, but the Eskenazi and experts there with airway management, I think that was probably the best decision. As long as he maintained, and he did maintain, so I think all in all, good job.
Yeah, it was a great run.
Yeah.
Great.
Did
You can
you?
imagine
Yeah.
how much on board though, and him not.
Yeah, 450 ketamine and 30 of the Tomadate. He's
And he just maintained until he got the
Why?
Just out of curiosity, I know you verified that IO, but did you ever attempt a second one or look for additional access?
no, we were just kind of shocked.
Yeah, I mean, I would be
We're
clear too, once you go through a whole while, I still talking to you
We're like, what is going on?
I mean, and that's why Andy wondered if it was any good. He said they got marrow and they put 1,000.
yeah, no,
With nothing.
Sure.
Yeah, because I wondered, after she said it, like,
That's a lot of meds, even for somebody that's resistant, that's a lot of.
and I had a conversation with the ER pharmacist. It was to talk with Ashley, those guys, of course, he's hypermetabolic at that time. Maybe he chewed it up that fast, but I have a hard time believing it. I mean.
That's a lot of sub-Q meds,
Yeah.
that's a lot of.
What's
Let's just say an hour later he takes a nap,
Yeah. I wonder what his day off regime is,
He is a chronic marijuana smoker.
Well, so is.
Fancy marijuana.
Chronic,
Yeah.
it's like floating every day.
Yeah. And I asked that if they thought that would make a difference.
His receptors are pretty bound.
I will say in talking to our partners at Eskenazi and things like that, in their education team, when I was building education, when we travel with the RIC Center to do burn education for their trauma program, or for their trauma education that we're doing for the RIC, they said a majority of the burn patients that we intubate do not need intubated. And so obviously, if you have that feeling that this patient needs intubated, please intubate them. I never want you to get in a situation where you're like, oh God, I should have intubated this patient 10 minutes ago and now I'm in a bad situation. So hoarse voice, altered mental status, those kinds of things, please always intubate those patients. But the 9% occlusion,
I've heard that too.
and so we over intubate, right? We always over intubate because we want to be cautious. We never want to get in that situation and be like, I should have done this the way.
Well, we're not trying to mark
No.
that, pulling the neck off the.
Right. And so
Trying to
you
leave out
saying well, I've never done this, but I have intubated, but I've never cried, never want to be in that situation. So, but in talking to their education department there, they're we grossly over intubate burn patients just because we're they were in an enclosed burn or we suspect that they have an inhalation injury. Now, in doing my own research and listening to podcasts and things like that, they're well, just bronch them. Just do a bronch. I'm well, then they're intubated. If we're bronching them, they're intubated. We can't bronch people in the field. We're not going to bronch people and be oh, we can pull that right out and just
I bought this on the.
extubate them, right? We'll just extubate them then. So if you have that feeling, please always do that. But their education that we do over intubate a lot.
At the same time, if I'm severely burned, knock me out.
Yeah.
So obviously, if they're over 50% burned, we're gonna intubate them just for pain
You can
control.
call it anyway, whatever,
They can't
but give me
even
the.
I
But I
want the propofol.
I think the school of thought of soot on the face and things like that to intubate, that is slowly going out of practice.
And you have to remember that we do not keep burns, whether they're 2 or 102, we do not keep burns.
Yeah.
They are the burn experts, so you're gonna hear from this facility, if you think you need to intubate, you need to intubate. Let them, they can figure it out when they get there, because that's not our expertise, that's not our specialty, we don't have people to do that, and we'll be the first ones to tell you that. So if you think you're gonna lose an airway, not be a problem.
I showed them my question.
Thank you, Robin. Thank you very much.
Yeah.
Great discussion, guys, too.
Again,
Next up with our educational is Megan Ellis. She's going to talk about pediatric respiratory.
on his way out there.
That's exactly.
Good job, man. All the pieces of that. You got ready, you got all your things ready, you knew not to waste time trying to get an IV, you went to an IO, great job. You called ahead to the hospital, hey, I got this is my intention.
The trauma alert
The
too,
trauma
love
alert
it.
piece of it, like, great job, I can't say enough. You did a good job, and you had, you even did your own presentation, so.
Probably got voluntold for that.
I might have talked.
Yeah, could imagine.
I said, boy, that'd be a great case. He goes, well, I said, yeah, that'd be a great case.
We'll see you in January.
Yeah.
All right, so I'm gonna talk about pediatric respiratory emergencies. We're kind of mid-season for pediatric respiratory season. We kind of look for these kind of October to March. So at the beginning of this, we're just gonna talk about some disclosures that I have. I don't have any invested financial interest in any of the things I'm gonna talk about today. I have some equipment with me. I'm not getting paid by any of these equipment producers or anything like that. I do have a case study in this, so please just keep in mind there is some confidential HPI in there or PHI in there. Just keep it in this meeting. Don't share it outside of this meeting. It is one of my cases. I try to be pretty, tried to scrub it of everything that I could. And then any information that I present in this is just meant for educational purposes. Please always follow your protocols and don't say like, well, Megan said to do this, and do what I tell you to do and not what else to do. So we're going to start with just super basic PALS basics, because we're talking about peds. And then we will talk about just some broad respiratory complaints, how they present, how we're going to treat them. And then we'll talk kind of a high level overview of some respiratory strategies for peds patients. And then we will talk at the very end about some other pediatric problems and how we can address the respiratory concerns that those patients have. So PALS overview, I think PALS is very different than ACLS in the way that ACLS is very focused right at like cardiac rhythms. We talk about cardiac rhythms specifically and kind of like when somebody dies from a cardiac rhythm, how to fix that problem, okay? PALS is very specifically geared towards how to prevent a child from dying, okay? So early recognition, and it's very focused on these, like this systematic approach and our screening process, okay? So, and the last time I was here, I had a lot of audience participation is what I asked for, and so that didn't change today. So audience participation, so we talk about these kind of evaluations that we do of our patients. So the PAT, you can tell me about the PAT.
Work breathing, appearance, and muscle tone.
Yep.
Accessory
then-
muscles.
Yep, and then, so PAT is the like first ABC, it is not the ABC that we consider, so appearance, work of breathing, and then what's that C? It's not circulation, it is color, right? And then we have initial survey, and it is what? This is the ABC that we know and love. So that A is what? Airway, yeah. Breathing again, and that's more in-depth breathing, right? Not just work of breathing. We talk about all the things that go with breathing.
Excuse me, sorry. Hey, guys, the strobes and stuff are gonna go off if they're having to test the cars.
No, you're fine. Then we get C, C is
Circulation.
circulation, then we get to D, disability, and E is exposure. So we're talking about respiratory today, but I feel like even disability and exposure still have to do with our respiratory patients, right? All of those things have to do with our respiratory patients. And then when we get to our secondary survey, that is still incredibly important when we're talking about our respiratory patients. If I have an asthmatic patient and I don't do this secondary survey, but I find out during my secondary survey that they have a history of asthma and they've been in the ICU 3 or 4 times for their asthma, that's going to tell me a lot about their asthma. Or they just were recently diagnosed and haven't been able to fill their prescription for all of their inhalers. That helps a lot. Okay. Or when I'm doing the secondary survey, they're a deep patient. Gee, that's going to tell me a lot about why they're breathing 28 times a minute. And I don't want to slow them down. I have to intubate them. Okay. So all of these things are incredibly important. Now, depending on where you are at in your healthcare journey, we're going to do all of these things simultaneously. Okay. So the PAT is what I call like the grocery store assessment. We can do it when we just look at our patients. Okay. So I call it the grocery store assessment because we're doing it anytime we look at somebody. You're doing it from the doorway in the line in the grocery store. The initial assessment, yes, when you're a new provider, I want you to be like A, B, C, D, E. When you become a more seasoned provider, you're doing A, C, E all at the same time. Now, when I'm precepting somebody or when we're talking to a new health provider, we say like, yes, keep it, stamped out like that. When we are seasoned, you're going to do it all together, but when you get lost during the week or when you're in like a negative feedback loop with a patient, then we're going to come back to home base with that initial and go, hey, where did I get lost? Hey, is that airway good? What was that breathing adjustment? What was my circulation? If those things aren't addressed, you are never going to get to D, right? So those ABCs are really important. So then we get to the respiratory categories. What are my 4 respiratory categories in PALS?
Upper, lower, tissue.
So tissue, and then disordered control of breathing, the one that doesn't have anything to do with the lungs other than something's not talking to the lungs to work, okay? And then our shock categories, because they do relate to respiratory today. And it's not only to do with PALS, everybody gets shock, but some of these shock problems really affect our kiddos, and what are our shock categories? Cardiogenic, distributive, obstructive, hypovolemic. Okay. So I put this slide up here. When we chart retractions, are we charting retractions first of all? Yeah. Are we charting where the retractions are? Right. So especially when we're handing off, it's important to say where the retractions are, because where the retractions are kind of means how sick our patient is. Okay. Intercostal retractions is probably the most mild form of retraction. Then as we get up here, like this is really bad retractions when we start tugging in up here. Okay. Belly breathing, not as bad, but when we start getting super sternal or super clavicular retractions, this is telling me that my kid's really working. Okay. Now, I know you're busy, I'm busy too. I'm looking for retractions while I'm listening to lung sounds. Shirt comes up, I'm listening underneath the shirt, and I can look for these retractions at the same time. I'm also looking for vertical breathing while I'm doing that. Okay. I can look for tracheal tugging. I can look at their face. If they're tripoding while I'm doing this, I'm looking at their back. I can see some of these retractions at that same time. Okay. They're on somebody's lap, right? That's when they're going to be the calmest for me. I've warmed up my stethoscope before I've done this, because all of the things I can do to make them calm while I'm assessing them, to make sure that this is not worse just because I am assessing them. But retractions limited increased vertical breathing. What are some other things that kind of touched on them, but some other things that indicate increased vertical breathing? Grunting. Nasal flaring. And that's hard to see if they have a nasal cannula, and you can kind of just pop the nasal cannula out a little bit to see if they got that flaring.
Drooling.
Drooling, altered mental status. Positioning, yeah. If they've got that tripoding or positioning themselves forward. Okay. So, crew, we're going to start talking about it. I know it's got like the bluest eyes, doesn't he? So croup, when I think of croup, I can hear it. Okay? And so croup, we talk about, this is this tracheal, larynx, and bronchi, so the upper airway. And they get swelling, which narrows their airway, and kiddos already have a really small airway. So with this small airway, this is why I can hear it, you can hear that strider. And it is on which part of the respiratory phase? Inspiration, right? So you get that inspiratory strider. I can also hear what? Yeah, the barking cough, right? What is it? Stroke, yeah, I can also hear the stroke now.
It's okay.
Uh,
I was like, I think it works.
So seal-like cough, inspiratory strider, sometimes they're hoarse. You guys in EMS are gonna get this call in the middle of the night. Okay? They get worse in the middle of the night. They're gonna present to the ER in the middle of the night. Yeah, or because parents are like, I can't take it. Okay? Some other things that they're gonna have, they might have a low-grade fever, some congestion, tachypnea, tachycardia. Increased work of breathing, they might need a little bit of with some oxygen. Okay, they shouldn't need a whole lot, but they might need a little bit. Okay. What
I would say some drooling. That's
so that's on my when should we start to sweat it?
okay.
Okay. How are we going to treat just general croup?
Keep them calm.
Keep them calm. We're going to give them steroids,
Racemic epi if you have to.
nebulized epi, and we want to give them some kind of either humidified air or oxygen, depending on what that O2 stat is. Okay. And so this is where I start saying, like, do you carry a bubbler on your truck?
Oh, your truck.
Thinking like a pickup truck, I was like, I don't know what that.
So if you carry a bubbler on your truck, this is who you use it for, or you can put a little sterile water in your little small volume neb. Just give them a little humidified air on the way in. Okay. Doesn't necessarily have to be warm for these guys. Okay. Just a little bit of moisture goes a long way for them. Okay. Now, when we start to sweat it is when they start drooling. Their tongue starts sticking out. They start getting altered. They start tripoding. They start getting really anxious for how you think they should be. Okay? That's when we start thinking about things like, what is the vaccination status? Okay? Did they get their Hib vaccine? Because if they are not current on their Hib vaccine, they are an excellent candidate for epiglottitis. Okay? And if they are a candidate for epiglottitis, nothing goes in their mouth anymore. They don't get temps, they don't get swabs, they don't get drinks, popsicles, anything. They get what? Mommy. Yeah, and so this is also a good point where we keep them calm. If they need an IV or something like that, we're going to try maybe once, but the more you agitate them, the more that oropharynx starts to swell. And that is a bad place to be. So asthma and reactive airway disease. So these are exchangeable to a point, okay? So this is narrowing of the airway in that tracheobronchial tree, okay? And so when this smooth airway starts to constrict, and causes edema and mucus plugging, that's when we get asthma. And so I can hear asthma as well. And what does it sound like? Wheezing. And so this is a lower airway, right? So the asthma diagnosis does not come until the age of 2. And so if they're under the age of 2, we call this reactive airway disease. Over the age of 2, we call this asthma. And so when we start to get this problem in this smooth muscle constriction, we need to treat with some specific kind of meds. Okay? What kind of meds do you think we treat with? Steroids? We're going to start with steroids if they're wheezing and exacerbated.
Bronchodilators.
Bronchodilators, and if they've got mucus, how do we dry up that mucus?
Anticholinergics.
Anticholinergic. So what kind of nebulized anticholinergic do you carry?
After
Atropine. So we need to give both together, so a duoneb. How many do they get?
Whatever the protocol says.
Whatever your protocol says, okay? So what do you do for an adult?
Same.
Right, so I think that we get really caught up in the fact that this is now this size, okay? And it makes everybody sweaty. And our heart rate gets high and our blood pressure gets high, and we go, I'm gonna give them one. I just think that they should have one. But if they still have adventitious lung sounds and they still sound wheezy and they still sound like they have mucus in there, they get all three, okay? We get really caught up on the fact that like they've had a lot and their heart rate is high, okay? If their lungs still sound like crap, they need to still be getting nebs, okay? We can't just be like, well, their heart rate's high. Somebody else will fix it, okay? So if they still have wheezing, they still need to be getting nebs, okay? So we're gonna give them oxygen, but guess how we give our nebs? With oxygen, right? So they're gonna be getting oxygen with their nebs, so they're gonna get duonebs times 3 if they still have crappy lung sounds. They're gonna get steroids at some point, right? Some kind of steroid, whether it's IV or PO or whatever they can get. And then IV fluids. Why do you think that we would give a patient with asthma IV fluids? All day, every day, we are losing respiratory droplets, right? Like me speaking right now, my mouth is dry. This kid has been breathing off extra respiratory droplets. That's like a lot, right? You can think of when you're coughing and you feel crappy and you're breathing hard, you're breathing off more respiratory droplets. They have this insensible loss and then they have an increased insensible loss. So they are now volume depleted and they don't even know it and you can't tell either, okay? So they are volume depleted. Also, when you're breathing heavy and you feel like crap, do you drink a lot of fluid? No, not really, right? So these kids are volume low. So we want to at least start them on a maintenance fluid. Now, if we have to do anything big with them, we need to give them a bolus, okay? Or if they look puny, which I don't know that I've ever seen an asthmatic that doesn't look puny, they need a bolus, okay? So we're gonna go on and do aggressive treatment with them if we need to. So they've made it through supplemental oxygen, duonebs, steroids, and maintenance IV fluids. If they still look crappy, we need to go on to like the bonus round, which is continued albuterol, max sulfate, if it's in a protocol somewhere, okay? Because we do it for adults. Why would we give max sulfate? Right, and we know that our smooth muscles are constricted. So they're contracting, we want to relax them. EpiIM. EpiIM, if I have to give that, that means this kid is sick. But if this kid is sick, we have to give it. If we don't give this, it won't get better, okay? We often find that epi is delayed because it means this child is ill. But if we don't do epi and BiPAP, this child won't get better. So then BiPAP is next. You carry a pediatric BiPAP mask, right? Neither did we until about a month ago. 2 months ago. You carry a small adult.
Medium and big.
So a small adult mask will fit most adolescents. Okay? It'll just be the scuba mask.
It'd just be like a full face mask.
It'll be like a scuba mask, right? But so you can consider BiPAP or get them to a place that can do BiPAP, okay? And then the dreaded bum, 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 intubation of an asthmatic, okay? And if we are going to intubate an asthmatic, we need to be fully prepared to intubate an asthmatic, okay? And so things that are going to make me incredibly nervous and think that I'm going to have to prepare to intubate an asthmatic are decreased air movement or a silent chest, okay? Profound hypoxia despite any treatments that I'm doing in altered mental status, okay? So up here, what it looks like. I know that you guys can read, so I'm not gonna read this whole slide to you. Difficulty speaking in full sentences, this is every asthmatic that we know, prolonged expiratory phase. So we're kind of like working towards this with any kind of distressed asthma patient. But when we get to a silent chest, and I tell you, asthma patients are going to sound worse the more you treat them, right? They have restricted airway, you give them NEPs, their lungs are going to get louder for you the more you treat them, right? I don't want you to think like you've done something worse. You're gonna start moving more air around. If they start sounding quieter, things are they're progressing worse for you. So that would be a sign that we're moving towards intubation. So if we're gonna have to intubate an asthmatic patient, we need to prepare, and that would be, I have my code dose epi ready, and I know how much I'm gonna give this child. And I like have it ready, not just like, I know what the dose is gonna be. I have it pulled up and prepared. I have IV fluid bolus given to them. Because what happens inside the chest of an asthmatic patient? What's happening in their lungs? Yeah, I saw AJ do it. So what's going on in their lungs?
It's an air traffic disease, so the lungs are.
Yeah, they're auto keeping, right? So they're trapping, their lungs are getting bigger. Can your chest get bigger? No. So as your lungs get bigger, they press down on the heart and the vascular system. And I've already said they're volume low, right? So it's pressing down on a fairly empty vascular system. So as it presses down on that empty vascular system, and that heart is trying to push out, right? It could do that for so long. And then we give our RSI meds and kill that sympathetic tone. What happens? The code. Well, you have your epi ready, but you try to mitigate that code by giving some volume, okay? You try to bolster that volume, okay? But you just gotta be ready. The likelihood that an asthmatic will code during intubation is pretty high. If you can get through it and not code, we love it, right? And then you'll have everything ready. You prepare for an intubation like you normally would. Other things for an asthmatic patient. I think that's everything I have now that I've completely scared you about asthmatic patients.
One of our medical directors, Dr. Yupnes out of Riley, intensivist, he actually says if you intubate an asthmatic and they don't die, congratulations, you did everything 100% correct.
Yeah.
50% of asthmatics we intubate will arrest. That's across the board, not just pediatrics. So like, be mindful of that. You should not take intubating asthmatics lightly.
And I think that the goal, again, as with any pediatric patient, is avoiding cardiac arrest, recognizing early symptoms, treating them aggressively. And so that's why I say, like, give the epi early. If you consider that, hey, I think that I might have to give epi, you probably should be giving epi. If it's even like in your mind at all, you should probably be giving this patient IM epi. Questions about asthma?
Could you potentially see JVD from that, from the air trapping and that extra pressure against the heart?
I mean, I suppose you could.
Would it be so significant where you could see that presentation with it? Because I mean, they're already small framed and everything.
I was gonna say, they're still volume low, like Hannah said, you might not, and the other thing about doing anything with these kids is as you're bagging them, you might have to like bag like so long to let that expiratory phase out. And sometimes you have to like manually squeeze their chest out. But I have not seen JVD on them, and I've taken care of some pretty sick asthmatics. I've intubated one accidentally. We didn't know that they were an asthmatic. It was like we were unpacking our bag, Hannah, and we were like, oh no. No, it was like a 12-year-old crew and intubated, and then as we were like, Jesus Christ, we can't get them on the vent. And like we're talking with parents, and they were like, well, they take an inhaler occasionally, and I was like, what inhaler for? They're like, oh, they have like reports-induced asthma, and I was like, oh, amazing, great news, I love it. So, yeah, good to know, so. So RSV, we're gonna move on to RSV. We'll talk a little bit more about asthma and NEB setup with a BVM in a little bit, so.
I don't know if they meant to, but there's a hand raised in the chat.
Oh, I don't know how to.
They should be able to unmute. That's like a very life. Somebody have a question?
Yeah.
Speak now.
Does somebody have a question in the?
Not too scared. They were like.
I know, right? Like, oh crap.
Never mind.
I don't mind.
Maybe I missed my accident. Nick has a question, oops.
If you have questions, text me or email me.
Yeah, if you just raise your hand again and I will answer. I would love group participation from people out there. I asked Kyle if anybody would participate and he said he did now.
It may have been you, but honestly, there's a hand next to Union Hospital.
In the next meeting.
Do you have a question?
You have a question?
So RSV is the leading global cause of respiratory emissions in young children. So upper respiratory symptoms, leading most often to bronchiolitis. It is often viral, but it affects 90% of children under the age of 2, or 90% of children under the age of 2 is who it affects. And then it does have a high burden on elderly adults. We do see this a lot between October and March. I'm sure everybody here has heard of RSV. We see a lot of congestion. We hear when we listen to these kids, you can almost like hear their congestion, like their nasal and kind of like upper airway congestion when you're listening to their lungs. They don't have a lot of like lower airway sounds, but you can hear their congestion. If they do incidentally have wheezing, you can treat wheezing, but we aren't just going to empirically treat these children with NEBs, okay? But we're going to do supportive therapy. If they have any kind of hypoxia, please treat them with oxygen. If they need heated, humidified air, we can do that. And then any kind of fluids that they need. They have a fever, treat the fever, et cetera, et cetera. So again, we're going to look at these children for increased work of breathing, any retractions, things like that, because it is imperative to avoid these things that are going to make us sweat. So any kind of apnea. We want to look for that because these kiddos are at risk for progression to a worsening condition that is precipitated when things start happening like lethargy or feeding, and those things kind of precipitate these respiratory distress failures. Questions about RSV at all? I feel like RSV has been like drilled into us over the last 5 to 10 years. RSV, like I said, leads to bronchiolitis. This is inflammation of the bronchioles in the lower airway. Typically seen in 2 to 6 months. It is viral from RSV. Congestion, again, these kiddos are more likely to have wheezing, but again, wheezing is not necessarily 100% going to be occurring. If it is there, treat with albuterol, but don't get tunnel vision and think we have to give these kids albuterol and get like stuck on that train track and only go down that pathway. Treat fevers, give IV fluids if needed, and heated humidified oxygen. Again, looking for lethargy, pale, poor air movement, prolonged cap refill, prolonged cap refill. Children, prolonged cap refill is like one of my biggest things that I try to talk about when I'm precepting. Prolonged cap refill is going to be one of your biggest indicators of a decompensating child. Blood pressure holds on forever, but prolonged cap refill is going to be one of your earliest indicators of decompensation. Pneumonia. I feel like most people know what pneumonia looks like, sounds like. It's no different in children. But these kiddos are going to hang on a lot longer than our adults do. And they will progress to shock pretty quickly after they've been hanging on for a while. So they might be kind of a mixed bag. They could have pneumonia and sepsis. And so knowing what to look for there to know, that they could be kind of doing double duty for you. The things, when I asked around at base, kind of what makes you worried when you have a kiddo with pneumonia? What kind of things do you want to look for? And one of the things that people said was underlying cardiac disease. So if you have a congenital kiddo who also has pneumonia, that's something that they would be the most worried about. Anaphylaxis. And so when I say anaphylaxis, clearly I'm not talking about just an allergic reaction, right? This is a hyper or an acute immune response that is overactive to some kind of outside force. So peanuts, tree nuts, bee stings, shellfish, etc. This could be the first time they have this allergy. This could be the millionth time they've had an allergic reaction. But this time it is the big allergic reaction. So what is the main treatment for anaphylaxis? Right? You can do all the other things too, right? We want to do all the other things as well, but the thing that's going to get them out of anaphylaxis is F. Okay? The main thing that we're looking for to tell us that it is anaphylaxis is some kind of airway involvement, plus, or they can have respiratory symptoms, hypotension, and syncope, hypotonia, incontinence, or skin symptoms and respiratory symptoms and those other things. Okay. You want to do 0.01 mg per kg of Epi 1 to 1000. Okay. Maxing out at 0.5 or whatever your protocol says. Okay. Other things that we can do is a fluid bolus if they're hypertensive, supplemental oxygen if they're hypoxic, epi drip if you have it in your protocol and they're remaining hypotensive. You can obviously redose that FEIM if needed, and then securing an airway if you are concerned. If you are concerned about airway restriction, what are you going to do with that tube size? Go about a half a size smaller, right? Foreign body obstruction. Taking you back to BLS here. If we are concerned about a foreign body obstruction, get it out. If you can't get it out, get below it. Okay? So we're going to work to get it out. These can either be full or partial. These are going to sound like Strider. This Strider's might be different though, right? Is it going to be just on inspiration? There's something there, so it could be on both phases of the respiratory cycle. Okay. We also might have wheezing depending on where it is. If this has gone all the way down in the lung, you might get wheezing as the air moves past whatever this is. Okay. Or if this is a full occlusion, we might have no air movement whatsoever. Okay. So we need to get whatever this is out of there. Obviously, if this is down in the lung, we probably aren't moving this. And we just need to get them wherever they can go to get it wrong. But if this is a full occlusion, we need to get this out. So we're going to do abdominal thrusts and back blows is the new updated.
Did it change?
It did change. We're going to do it for everybody, abdominal thrusts and back blows. And so even if Barry was choking today, we would do abdominal thrusts and back blows.
Swally stands up.
I guess, yeah.
Okay.
Everybody try.
Upward.
Everybody.
Yep.
Yeah.
Very.
Just take a mat, back.
I know you would.
Yeah.
Like up like this.
And then
Do the downward work.
if you were to become unresponsive, then we would change to CPR with the addition of looking for the obstruction prior to putting any air in his mouth. Never doing a blind finger sweep. So some respiratory strategies we have. These are the things I'm going to go through. The supplemental oxygen, clearly you carry most of these things with you. I don't know that you guys carry a styrofoam cup. Okay. But the styrofoam cup is probably my favorite. I learned about it when I did my EMT class. It was something that I never even considered as a nurse. But it's probably one of my favorite things. And I think that it probably would be like the least confrontational for a child. The one thing that I do want to talk about is when you are considering pre-oxygenation, it is our standard practice at Lifeline, and if anybody gets pain or sedation, they go on the end title. Is that your guys' practice as well? At your agencies?
Sure.
Yeah? Then when you go to pre-oxygenate for intubation, do you switch that out for a high flow nasal cannula, or do you leave them on the end title one?
High flow cannula. We don't
have
have
in our
cannula for.
Okay, but do you switch out the end title, or do you leave the end title one on? Yeah, do you know that maxes out?
Yeah, like 4.
Yeah. So you're pre-oxygenating it for liters.
We don't wanna do that.
Right.
Yeah.
So that's my big like, hey, remember, at least switch it out to a regular nasal cannula.
You don't offer apneic oxygen. Well, if you're done.
Right. So during your attempt, you need to pop it off into a regular nasal
CO2
cannula.
nasal cannulas do not administer oxygen very well. They're just very CO2.
Yeah. It's just monitoring your end title. Okay. So they are great for what you want them to do for end title, but they are not great for what we want them to do during intubation. I'm just as guilty in a pinch when you go to lizard brain to intubate. It is like the last thing you're thinking of to do. Okay. So high flow oxygen became wildly popular during COVID, right? If we were already using it for some populations prior to COVID, but during COVID, it was like the hot new thing. Everybody got put on high flow, right? So it is great. You guys have high flow cannula capability at all? I heard City, no. Transcare, no. You guys don't even carry like the cannula that goes up to like 10. Okay. Would you take it from an outside facility to transport? Okay. So understand different sizes for different size of patients, right? So no, if you take like a child on a high flow cannula, we should not be taking up more than 50% of the nares if you're doing that, okay? More than 50% of the nares, you're now providing pee, okay? And for our little lungs, we don't want to necessarily be providing a lot of unregulated pee to these kiddos, okay? Also, when we are doing this from an outside facility in our ambulance, if we are not using this device, which we aren't, right? Like we're not taking the Bishop Cal from outside. We want to make sure that we're at least taking the bubbler with us, okay? Because the heat and the humidity is what makes us comfortable at high flows, okay? Max of about 2 liters per kilo is a good rule. This looks just like discomfort at high liter rates looks just as much like distress because it's uncomfortable. Like they won't be able to keep a pacifier in their mouth. They won't be able to feed. They will look uncomfortable. Imagine like an ice cream headache constantly. That is what this looks like. It feels awful. We have shown up at bedsides at places all across the state of Indiana and been like, oh wow, you look miserable. Let's turn down your flow like even just like 3 or 4 mils. And then they're like, oh, thank God. I can breathe out. It's amazing. Okay. So just remember. And then also, this is not a replacement for ventilation. This is providing oxygenation, right? Just at a high rate. If they need ventilated, this is not doing it. This is not providing gas exchange. Okay. You need BiPAP, or if they need like controlled ventilation, they need intubated. Okay. This is a bridge to therapy. So I understand I said like a small mask could work, not for this size, okay? Like this is not a small adult mask, okay? So non-invasive, all right? We have some non-invasive stuff we can do. So bi-level. You guys carry CPAP? Yeah, probably not this size. But you carry BiPAP as well. Just CPAP, okay. So talk to me about the difference between CPAP and BiPAP. I know Transcare carries BiPAP and stuff, because you guys have that, those Hamiltons.
Our beds do BiPAP.
Okay, beautiful. So talk to me about the difference between CPAP and BiPAP.
Continuous versus bi-level.
Yeah, so continuous, always pressure in, bi-level, pressure in, and pressure to support through expiratory, right? So we have now 2 settings to set for BiPAP. What do we think those 2 settings are?
Keep motor going.
So PEEP, yes, and then IPAP. So EPAP is PEEP, IPAP or inspiratory pressure, okay? And so inspiratory support, like pressing in, and then keeping those airways open, right? Like keeping those airways open. So we need to set both of those. So our starting, where do we start? Does anybody know? So we want to start at 10/5, okay? And that's just like a safe place to start for everybody. Clearly, we might have to do some adjusting depending on who we're taking care of, okay? So 10/5, okay? And so that's 10 of inspiratory pressure and 5 of PEEP. Makes sense because everybody has 5 of PEEP, right? That's just where everybody lives. Okay. Now, we also have to set the FiO2. And if this patient is acutely needing set, where do we think our FiO2 should be? The highest it should be, 100. We can always titrate down. Okay, and then a backup rate. And it is that, a backup rate. So if I am currently breathing 24 times a minute, should my backup rate be 24 times a minute? I'm gonna have to sink exactly 24 breaths. So should it be 24 times a minute? Or should it be the minimum breaths that I should be taking? It should be the minimum breaths I'm taking, okay? So if I am breathing 24 times a minute because I'm nervous because I'm giving a lecture, I don't want to set it at 24. What's a normal adult rate? 12, I heard 12. So let's set it at 12. I'm gonna watch this patient. If I go from 24 to 12, I need to go, what's going on? Something happened. Why'd you start breathing 12 all of a sudden? Are you just relaxed? Do you feel much better about giving your lecture? Like, are you unresponsive? Hey, are you okay? Are you doing better? Are you awake? Are you with me still? Do you have a pulse? Okay. It's a backup rate. Okay. Because if we set it at exactly what they're breathing, they are going to have to work against every single breath they're taking, and it's going to have to sync up exactly. Does that make sense when we set it exactly at what their rate is? Okay, so those are our settings. Those 4 settings are what we're going to do. Now, if we want to increase oxygenation, which one do you think will change? So FiO2 is already at 100. What other one of those messes with oxygenation? PEEP. So we would need to increase PEEP. We wanted to increase gas exchange. So tidal volume, we haven't talked about yet, so I'm not gonna mess with it because there's not a bunch of overabundance of people that deal with BiPAP in here. So what's the other one we could change? Rate. But they're spontaneously breathing, the pressure. Yeah. So we could increase the pressure a little bit. Okay. There's also, if we want to get really into the nitty-gritty, there's a thing called the delta P. You subtract the 2 numbers from each other, and you can increase the distance in the numbers. That's the tidal volume. When you increase that distance, that increases the tidal volume or the push. Okay. But that seems like a lot for today. Okay, BVM basics. I think it is incredibly important to BVM children correctly. How do you guys feel about it? Agreed, right? So a pediatric BVM that comes straight out of the bag should come like this. This has an adult mask, but
Pretend.
yeah. And so there's a pediatric mask over there, but it's because we use pediatric BVMs for our adults so that we can't get really excited. So it should come like this. Do yours look like this? Does it have all this fancy schmanciness on it? Okay. So am I gonna be in the, like, do people see me on this?
No.
Okay. So,
I mean, the camera's trying to follow you.
oh, okay. So I think it is important that a pediatric BVM come with a manometer and a PEEP valve. Your guys have at least a PEEP valve on it. Yes. So the manometer and the PEEP valve are important. So first and foremost, when you're bagging any kind of pediatric or child, you should have a pediatric size. You should have the appropriate size, right? Either a pediatric or an infant size BVM. Okay? Because if you're using an adult BVM, squeeze all the way, their poor little lungs are gonna go. Okay? So when we squeeze it, we're looking for how much volume to go in.
Not to see chest rise and fall.
That's it, right? And not to see chest rise and fall. Now, this manometer is important because it keeps me safe. Okay, stoplight system, green is good, yellow is less good, red is bad. Okay. So this is essentially our inspiratory pressure or our airway pressure. Okay. So when I'm looking for my airway pressure, I know that this is good. If I'm not getting chest rise and fall with the green, it's okay to go a little into the yellow. Okay. To see if I'm getting chest rise. Maybe I need to reposition my mask. Okay. Maybe I need to suction. Maybe something's in the way. Sorry, you think I'm much better. Maybe I need to go into the yellow. Maybe I need to do something different. Then our PEEP valve, everybody knows how the PEEP valve works. Yes. Yeah. When we're adjusting our PEEP valve, I say to adjust it by about 2 at a time. And we're looking for what to increase as we're adjusting our PEEP valve.
Yeah, I agree with that. SB.
Yeah, the SpO2, right? So we're adjusting by 2 at a time. For a pediatric patient, I would say it's safe to go to about 15 on our PEEP. Then, let's see, make sure I'm staying on task here. We want to always pull the jaw to the mask. We see ultimately when we're failing to get to chest rise and fall, we just push it further and further and further down into the bed. Okay. On a pediatric patient, their facial structures are soft. That's not going to work. We're just going to smash it down. Okay. And then a bit of show and tell. I want somebody to show me how you put a neb together to bag it in. Has anybody ever done this? Or like, why would you need to do this?
Because they're constricted, they still need.
Yeah. Yeah, so your patient has gone into respiratory failure, but they were some kind of, you know, COPD, asthma, something.
Constriction in the south.
Oxygen. It's be sideways, so.
Yeah.
Yeah, but.
Right. So to keep it straight, we can do this. I tried to do this earlier. Nope, this is the mask. How did I do this earlier?
This part would go.
This to something. I just did it. So my whole point to this is we practice so that in a pinch, you're not like, my patient's dying. They need bagged. How do I do this, right? I know. So somebody else is bagging and then you're doing this to the side. So this was somewhere. I need Alex. Alex is all about how it goes and he just puts it together fast.
A lot. I'll be all in it. So we went.
So that when it's sideways, it still goes. Yeah, I know. It was, oh no, there's just to the side. It's like this. I was like, this was to the side. This needs aired up clearly. Okay. It just took me a minute. Okay. But this is why we want to practice so that in a pinch, we can do it. Okay, I'll leave it, we can practice, yeah. Okay, so ventilation strategies. Again, I understand that you guys don't carry vents. I know TransCare does. Yeah? Are you guys acutely putting people on the vents in the field, or is this just transportation vents? Okay, so this slide is meant for transporting vents, but also there's a lot of good information here that even applies to vacuum people, okay? We can kind of translate this to vacuum, okay? And then also, if you also work transport or you have goals of working transport, so then basics, we've got kind of 5 things that we're gonna look for setting on the vent. So tidal volume, PEEP. So tidal volume is VT, PEEP, I time, F is respers, and then FiO2, okay? Tidal volume, safe tidal volume, 6 to 8 mils per kilo. That is what our goal tidal volume is, and if you notice that is ideal body weight. Most of our children are ideal body weight. We always want to shoot for the low end. We want to shoot for 6 mils per kilo, okay? Again, if we are bagging, we're going to just look for chest rise and fall. PEEP of 5, adjust as needed. I time. What is I time? Inspiratory time. Why do you think that this changes?
Way to correct this too.
Okay. So if I breathe 60 times a minute, or if I breathe 12 times a minute, my inspiratory time has to be different, right? To adjust for getting that many breaths in a minute. So at a newborn, it's 0.5 because they breathe hella fast. Or at like 15 and older, it's going to be 1 second. Right? That makes sense?
Yeah.
So we automatically adjust that, right? Because our rescue rate adjusts. Respiratory rate, it's going to be driven by age and what's going on. Okay? We've kind of talked about this a little bit as far as age, but what's going on with our patient? So if they're an asthmatic, are we going to have a high respiratory rate or a low respiratory rate? We have a long expiratory phase. We have to adjust for that. So we're going to get a long time to breathe out. So it's going to be a low rate. Okay. And we're going to actually listen for that expiratory phase and then give a breath. Listen for that exhalation. Give a breath. Listen for that whole time to breathe out. Give a breath. Okay. Same thing. We've got a DKA patient and they were breathing 30 times a minute. I got to breathe that fast. If I slow that rate down to what is normal for that age, what's happening to all that CO2 building up? They're going to code, okay? Or an overdose, a salicylate overdose. It's building up, building up, building up. They were working on something. They were breathing it off. FiO2, we talked about, it's going to be set at 100, titrate down as needed, okay? Waveform end tidal. I know you guys all carry it. Everybody's getting put on it. They stay on it, okay? If you pick up somebody at outside facility to transport them, they get put on it if they weren't on it, okay? Because it's going to tell you if your tube is still good, if your blood pressure is still good, etc. What is dope in the respiratory setting?
Mnemonic used to check to make sure the artificial airway is good.
What does it stand for? Somebody other than Nick and AJ.
Displacement, obstruction, pneumo.
Equipment, very good, yeah. Okay, it's going to tell us what's going on anytime there's a big alarm, our patient changes. We automatically do that dope mnemonic to see what's going on. Okay. So we kind of talked about this during BiPAP. What do you think we would adjust for those 5 things at the top for high CO2? So we're looking for ventilation problems, gas exchange problems. What do we want to change?
Rate, your frequency.
Rate? volume. We aren't gonna change eye time because eye time's set for age. So rate and tidal volume. SpO2 is different. What are we gonna change? PEEP and FiO2, right? Very good. Now, peak inspiratory pressures. That's something that is going to be specific on the vent. If we start getting high pips, but we can feel high peak inspiratory pressures. We can feel that in the bag. What's it going to feel like? Yeah, resistance. Very good. Yeah, we're going to feel resistance on the bag. Okay. What do we think that might be an indication of? If we're getting resistance while bagging, some kind of obstruction. So we could have a tension. Our tube could have migrated and now we're main stem. We were only bagging one lung. Okay. So there's some kind of a problem. So what are we going to look for? What was it?
Chest rise and fall.
Chest rise and fall. CO2 changes in our CO2. And any other indications of like a tension. So what'd you say? JVD. Yeah, JVD, decreased lung sounds, hypotension, tachycardia, hypoxia, etc. So ET tube selection and tips, there is no ego in intubation. Okay. I will tell you, I show up places and people are like, oh, thank God you're here. We've been waiting to intubate this child until you got here. And I'm like, oh, good, because I've done one this year. A professional. So experts do not perform pre-hospital intubations on babies and children. I don't know how you guys feel. I might have just cracked your ego. You guys might feel like experts and professionals in pre-hospital baby children intubations. But when I say that, it is because I am trying to instill in you the courage to practice. So because we are not professionals, we are not doing hundreds of thousands of pediatric intubations every year. Practice monthly, weekly, in your fire station, in your ambulance station. Practice these so that it becomes absolutely routine at 3 in the afternoon or 3 a.m. so that you know what size tube you need, that a bougie won't go through anything smaller than a size 4 ET tube, that you know that you should give atropine for anybody under the age of 1, that you know what size, tube is safe to use a tube tamer on, that you know what drugs you should give and what the dosing is, so that it just rattles off and it's no big deal, okay? So that you're not an expert, but you're pretty freaking close, okay? And that you feel confident and that your partners feel confident with you. All infant and pediatric endotracheal tubes should be cuffed unless they have recently come out of a vagina in your presence, okay? The only one that is getting an uncuffed tube is a neonate, all right? That is a recent change, I feel like, for some people, but everybody gets a cuffed tube. You can either use your weight-based tape or like card that tells you what size tube everybody's going to get, or you can use this calculation, size equals age divided by 4 plus 3.5, and that's your cuff tube. And then depth is size times 3, or you can watch that black line at the end of the tube go through the cords. Okay. Know that those cords are going to be omega shaped and floppy and terrible, and you should use a Miller blade. Okay. We're going to use commercial securing devices as much as possible. Okay. If we think that this kid's going to move around and have a really floppy head, or they're going to be really rambunctious, we might even put a collar on them. Okay. Just to decrease as much head movement as possible. Because tiny movements in tiny tubes are big movements. Okay. And then again, waveform and title for confirmation and continuous monitoring. Any questions about ET tube selection or tips or anything like that? Okay, so this is my case. So we had a 1-year-old that we picked up here locally. The initial call out was for an unresponsive cyanotic child that got into some pills that were supposed to be dispatched from a deceased loved one. They were in the care of an elderly, like a grandparent, that they lived with. Older siblings, and then we're having like a party with these little pills, and older sibling went and got the grandma and said, younger sibling is unresponsive and cyanotic. EMS got to the house and found child not well. Gave some Narcan because pills were unknown. It was just a mixed bag. So appropriately gave Narcan and an IV fluid bolus. Child still had a pulse, was breathing. Gave those things and transported outside facility. On arrival, child was bradycardic with periods of apnea. Labs disclosed to us, big ones that stood out were a potassium of 5.8 and a glucose of 131. We were dispatched to come by ground to transport a patient to Riley PICU. So we arrived to find child laying face down on grandma's chest on the EMS or on the ED cot, requiring constant stimulation to maintain vital signs. Kid was pretty somnolent, frequent periods of apnea, heart rate in the 70s and 80s with frequent activity. Limp would arouse to pretty deep tactile stimulation, and my partner was putting them on the monitor while I was getting a report in the room and wasn't really reactive to that. So how's everybody feel about that kid?
Red flag.
Yeah.
Yeah, I wasn't thrilled, especially to be transporting by ground. Like, didn't seem like a great time to go an hour and 20 minutes by ground in an ambulance. So we called PICU, got a plan together. We requested upgrade to rotor, and they requested that we go ahead and secure the airway. So gave an IV fluid bolus to increase preload prior to intubation, just because we didn't know what kind of substances this child had ingested, and with the ectopy and the low heart rate. We got everything together for intubation, pre-oxygenated, put a shoulder roll, RSI with ketamine and rock, placed a 3.5 tube. Everything was confirmed, and we secured with tape because we were really bad that morning, and we skipped over the fact that we did not have a tube tamer in our bag because things happen. And so when we looked for our tube tamer, we were like, okay, so we're going to tape tube, and we were taping a tube for the very first time ever. I'd never taped an ET tube. So taped a tube, gave post-intubation sedation, put this kiddo on the vent, and within minutes we were getting high pips. Vent was alarming high pips. We were getting downtrending heart rate into the low 70s and just below 70s, downtrending into the low 70s, O2 sats decreasing, and end tidal was climbing. So what do we think is happening? What's that?
Obstruction.
Yeah, something's happened with the tube. It's obstructed. Something's going on, right? So we doped it, took them off the vent, started bagging with high flow O2. And then we found lung sounds were decreased to the left chest, and our marker on our ET tube was deeper. And so in talking with our respiratory therapist that works in our education department, she said, it is likely, she goes, you just do it and you don't even know it. When you're taping the ET tube, you advance. She goes, because you don't want to pull it out, so you push it in.
That's what I wondered if while you're taping it got me.
And I was like, well, I'm glad I pushed it in instead of pulling it out, I guess. And so we started CPR once our heart rate got into below 60. And gave atropine as opposed to epi just because we knew that there were some kind of cardiac meds in these mixed bag. And so gave atropine, immediately responded to the atropine, got a chest x-ray to confirm right main stem and pulled the tube back to where we wanted it. And went on our merry way. Got the kiddo back on the vent, no longer had high pips. Resedated. We ended up rendezvousing at the airport to get in our helicopter. And while we were at the airport, we got a tube tamer on. So that we wouldn't have any more migration of the tube. Kiddo was fine for the rest of transport. We did give one more fluid bolus, because max hit 50s. And she responded well to the fluid bolus. Handoff was unremarkable in the ICU. So there's a couple things. Does anybody have anything about that case? We didn't get any kind of follow-up on it. Anything about that?
Glad it was you, not me.
Do your track checks.
Yeah, that's exactly what my thing is we looked at the back, we did everything, and we just we were pretty complacent about it. We were like, all of our equipment's here, it's all good. And I will tell you every day from then on out, I'm like, adult tube tamer, pediatric tube tamer, check. It's something that I absolutely double check now. So that I have since had a tutorial on how to tape pediatric tubes from our respiratory therapist that works in our education. And I taped it in the middle of her mouth, and she was like, nope, tape it over to the side really tightly. And I was like, thanks, I will do that. And if I was taping, I probably would do the C-collar thing, just to make sure that there wasn't as much movement of the head with tape on. But yeah, it got a little dicey for a minute, and we were like, oh, I didn't like that. That kind of sucked. Glad that it had a good outcome, but it can happen, can happen to anybody at any time. We had a perfectly good intubation, and it happened afterwards, right? And so it's going to happen when you're moving, when you're doing all the things. And so knowing that always be looking at where that tube is and making sure that tube is still exactly where you wanted it. So other to consider, we've already kind of touched on DKA and tox, seizures and conscious sedation. So these are going to be people that we probably have given meds to. So toxicology, they've probably taken meds themselves, right? Seizures and conscious sedation, we probably caused this disordered control of breathing. Okay? Do we want to reverse this disordered control of breathing? If we give them any kind of a reversal, what will happen?
Back where they were whenever they needed.
Yeah, they will seize, or they will have pain from whatever we consciously sedated. So we don't want to reverse it. We just want to support them and do whatever we can. And then trauma and neurological conditions. They might have disordered control of breathing as well. So we might have to support them, intubate, do whatever. My big thing here is while we are supporting them and doing anything that we need to do respiratory wise, we desperately need to consider pain, sedation, things like that. Because whatever's going on with them, if we don't do those things, we're gonna increase whatever is acting on them to make their respiratory dysfunction happening. Questions about any of those? Putting it all together, we know now what in BiPAP and ventilation we need to change or adjust to fix ventilation and oxygenation. We've learned some strategies and starting points. Any questions about anything? I talked to you forever today. I appreciate your guys' time.
Thanks, Mike.
Yeah.
Appreciate it.
All right, guys, on the screen is a QR code to register to sign in. That is a link that will go out to fill out the form. You can do it that way, or you can use the QR code. Be sure and get that, do that, put it in, so we can keep track of, get credit for being on audit review. Anybody have any questions, anything at all? Megan, again, everybody that presented, thank you guys very much. All right, guys, that's all we got. Thanks.